This is the Union CDC Late Breaker session, which has been going on for a number of years. We had an incredible number of abstracts for this session, over 150 globally distributed. We had a reviewer panel of about 20 people who thank you if there are any reviewers in the audience for scoring. And what we've chosen today is the very best and a very diverse, both in terms of topic and regional distribution for the sessions. So it's my pleasure to start the first session, which will be presented by Leo Martinez, and it's called Tuberculin Skin Test Conversion, and Primary Progressive Disease in South African Infants and Young Children. It's a longitudinal birth cohort study. Welcome, Leo.
Okay, thank you. My name's Leo, and I'm going to present some work from South Africa. Here we go. So some background. So tuberculosis is a leading cause of global childhood mortality, and most of these deaths occur below 5 years of age. And approximately 1 million children get tuberculosis every year, from recent estimates, and half of these are below 5 years of age. And most of these cases are undiagnosed, the vast majority. And this is concerning because undiagnosed children have very high mortality rates. Those below 5 have mortality rates above 40%, according to some studies. So despite these alarming rates of mortality and burden among children, the epidemiology of tuberculosis in infancy is not very well understood. So there's been few prospective studies that are community-based that have measured incident TB among children, young children, and a few studies have measured prenatal and early life risk factors for progressive disease. Due to this, pragmatic approaches for dealing with tuberculosis in children are lacking. So the objectives of this study was to assess the burden of tuberculin conversion and primary progressive disease in infants in a little bit outside Cape Town. We also tried to identify prenatal and early life risk factors for the development of tuberculosis infection and disease as another objective. And all these pictures are participants in our study. So this is called the Drakenstein Child Health Study. It is still being conducted, but it was this portion that I'm presenting is from 2012 to 2017. It's a longitudinal birth cohort study among pregnant women that 20 to 28 weeks gestation, recruited, followed until they gave birth, and infants are followed until 5 years of age. The study measures a range of diseases, not just tuberculosis, and so all these diseases are evaluated until 5 years of age. For the data that I'm going to present, tuberculin skin testing was performed at 6 months of age, and then 12 months of age, and then annually until 3 years of age. And I'm going to talk about that a little more in a subsequent slide. Tuberculosis was continuously evaluated at regular and sick visits until 5 years of age. Participants were told if they have any symptoms, they were told to come to the clinic as well, not just at regular visits. And this is the location of the study on the top right. So this is the study profile. We enrolled 1,225 pregnant women. There were exclusions based on infant death, based on mothers not loss of follow-up from mothers, and there was 1,143 live infant births. Some infants were terminated perinatally, and there were some childhood deaths after birth, and they were excluded. And so we included 915 infant mother pairs that had tuberculin skin test results and disease follow-up. So the first study definition that we looked at was tuberculin conversion. So infants were considered infection-free at birth. We used an induration reaction above and equal to 10 millimeters. There's, of course, an issue with tuberculin boosting from multiple TST tests. So we took an approach with this specific outcome. We censored any child that had reactive but negative tests, so those between 1 and 9 millimeters. We censored these because we thought they might boost if we gave them subsequent tests. Infants, as I said before, infants were tested at 6, 12, 24, and 36 months of age, or until censored or positive. For pediatric tuberculosis, again, this is a difficult diagnostic measure. So we tried to take a more comprehensive approach. We had 3 different definitions. In the middle was our primary definition, which was all tuberculosis cases diagnosed. So clinically, radiographically, suggestive results, or microbiologically confirmed results. So that was our main outcome. We also, on the right-hand side, we had only microbiologically confirmed cases, was another outcome for this, for pediatric tuberculosis. And then another outcome was only microbiologically confirmed or radiographically suggestive cases. So, so multiple definitions. So some demographic features, 22% of mothers were HIV seropositive. This is a very high HIV burden area. There was a very strong antenatal ART program, and all these mothers were put on ART. So only 2 infants were HIV positive, which is below 1%. There was a high prevalence of lower respiratory tract infections, so almost 50% of kids had at least one lower respiratory tract infection, and 22% of these were severe. And 8 in 10 women breastfed, but this was discontinued before 6 months in the majority of those that started it. So these are some of our results. This is cumulative hazard of both conversion and tuberculosis, and the 3 definitions of tuberculosis disease. You can see here is tuberculin conversion, and again, this is cumulative hazard, so it adds over time. So we had, and you can see this is the axis for tuberculin conversion. So we found very, very high rates of conversion in this population. The rate was 11.8 per 100 child years, and 147 kids converted their skin tests by 3 years of follow-up, which is very, very high rate, which means transmission is happening at a very high rate. And for incident disease, so the white bars are microbiologically confirmed cases, the gray bars are microbiologically confirmed or radiographically suggestive cases, and then the black bars are all diagnosed tuberculosis. So you can see also we found, and this is the axis for tuberculosis disease. This is cumulative hazard, and you can see that the rates are very, very high again. It reaches, it's very high, especially in the first year to 2 years of life. And then it a little bit stagnates after that. But it reaches above 5%. And for all diagnosed tuberculosis, the rate was 2.9 per 100 child years, which is equates to 2,900 per 100,000 population. For microbiologically confirmed tuberculosis, we found rates of 0.7 per 100 child years, which is 700 annually per 100,000 population, which is still incredibly high, considering not all kids are microbiologically confirmable. So for my second objective was to measure some outcomes or some risk factors for tuberculin conversion. So in univariate analysis, we had maternal smoking during pregnancy was a risk factor, but it was not statistically significant. Male sex was a risk factor, which is interesting. And also the number of other children in the household below 5 years of age. If you had more, then that was a risk factor. Okay. But after multivariate analysis, only male sex was a risk factor. For progressive disease, we found that maternal smoking during pregnancy was a risk factor among all diagnosed tuberculosis for that outcome. We also found that tuberculin skin test conversion was a risk factor, which makes sense. And we also found that IPT therapy was extremely protective, so it had a hazard ratio of 0.22. Last, if you had a lower respiratory tract infection, that was extremely, that was a high risk factor as well. It could be due to the tuberculosis itself, that they're getting lower respiratory tract infections, but we found that 75% of kids that were diagnosed with both diseases had over 2 weeks diagnosis apart from each other. So we think that these are happening separately, at least a proportion of these cases, these dual cases. We also found a dose response with lower respiratory tract infections. So the more lower respiratory tract infections you had, the higher the hazard ratio for tuberculosis. So some conclusions: we found very high incidence rates of tuberculosis infection and disease in the South African birth cohort. Much greater focus should be placed on the first years of life as a high transmission burden and clinical tuberculosis expression period. Implementation of multifaceted interventions is urgently needed. So IPT or integration of pneumonia and tuberculosis programming, something that some types of interventions to pick up this huge disease burden among these kids. So I'm just one part of a very, very large group. Heather Czar is on the right-hand side, and she's the mastermind of this study and recruited and did everything for the study. I'm kind of just tagging along. And this is the whole field team and the lab team and everyone involved. Thank you.
Coming to the microphone and identify yourself. We'll have time for not too many questions, so get there fast. Just quickly, you didn't report ARI, annual risk of infection. I'm just wondering, annual risk of infection?
So we found for tuberculin conversion, you're saying, for infection. So we found 11.8 per 100 child years. So you could interpret that as 11.8 conversions annually per child year, which is basically...
That's your annual risk of infection.
That's another way of, I think, another way of saying the same thing.
Okay, microphone one.
Lourdes Garcia from I'm Lourdes Garcia from the National Institute of Public Health. I didn't get if these children were vaccinated with BCG, and given these results, what would be your comments?
What was the last part? Sorry, I missed the last part.
If they weren't, or if they were, what would be your comments, please?
No, yeah, it's a good question. I should have put that in the demographic features. 100% of these infants were vaccinated, which is also another area that you could say is concerned because of this such high burden, even though they're BCG vaccinated.
Thank you.
Thanks, good question.
Thanks. Gavin Churchup from the Aurum Institute, great presentation. You didn't mention whether the mothers were screened for active TB shortly after delivery, so whether you had excluded active disease. And then what was the indication for IPT in the infants? So was it TB in the moms? And what duration of IPT did you give?
So we gave, I think 9 months or 6 months IPT. And then we also
active TB in the moms.
So we also measured active TB in the moms during pregnancy. They were all treated before enrollment, and also we asked moms if they were ever diagnosed in the past with tuberculosis. We also did that. There were low numbers in general, especially for being ever diagnosed because it was self-reported, we think. And so due to low numbers, we found an association, but it wasn't statistically significant, partly due to low numbers.
And what was the indication for starting out?
Okay, we don't have time, sorry, we're going to have to, we have quite a few.
I can find you after. I can find you after and answer.
Rick O'Brien from the U.S. One question relating to IPT, based on what I saw, it did not appear to be significantly protective, which would be a surprise. And the other finding that I thought was surprising was that it didn't appear to be any additional cases after age 4.
Okay, yeah, so IPT was protective for our major outcome for tuberculosis disease, so all diagnosed patients, it had a hazard ratio of 0.22, so it was highly protective and it was statistically significant. It also had a similar association when we used another definition, so microbiology confirmed or radiographically suggestive, but the confidence intervals were wide, I think partly because a few cases, but so it was protective. And then what was your second question, sorry?
That there were no additional cases after age 4.
Yeah, the vast majority of our caseload was in the first 3 years of age for all of our tuberculosis disease outcomes. So that's why we think, and we push this more, is that the first 3 years especially should be focused on, we feel like, from these results.
Thank you.
Thank you.
Awesome. We have 2 more questions. At microphone.
Pawisha Khan from London School of Hygiene and Tropical Medicine and IRD. Thank you for your presentation.
Thanks.
I was quite interested that you didn't present anything about known household TB contact and whether maternal HIV status was a risk factor for conversion.
Yeah, so we did measure household contact in the previous 12 months prior to enrollment. And we found that it was a risk factor, but it wasn't statistically significant. So that's why I only included, we had like a range of factors, and I only included those that were statistically significant here. But we also found that most of our TB cases that were diagnosed did not have a household contact, a known household contact, which was surprising to all of us. And either there's some reporting issue from self-reporting, or they're getting it from somewhere else, or something else is happening. We're not really sure.
And the maternal HIV status?
So that wasn't a risk factor for conversion among,
Okay.
yeah.
Thank you. Last question.
Frank Collins, University of Amsterdam. Thanks, great work.
Thanks.
Methodological issue. In the multivariate analysis of the disease outcome, you include as a covariate tuberculin skin test conversion. To me, that seems to be in the causal pathway, which means that you may be over-adjusting and you may actually miss significant covariates. Have you looked at it as well after taking out skin test conversion?
Yeah, after we take it out, the other factors that we list there are all still statistically significant. So I think they change slightly, but they all stay statistically significant.
But you don't miss others. You looked at where other factors would be, if they would be added, would now contribute to the model.
Yeah. We looked at other variables. We looked at like all suggested variables that were suggested based on a univariable model, and none of those changed either.
Thanks.
Thank you for that. But one is a good point. There may be some diagnostic bias based on the TST because, and this is just a limitation maybe, it's part of clinical diagnosis. So
Next step could be a causal mediation analysis as an alternative.
Lots of work to do, Leo. Excellent. Thank you so much.
Thank you.
Ana Telez, she's going to be introduced by Jesus Gonzalez Roldan, and the title of the talk is Improving Tuberculosis Laboratory Capacity in Mexico, Evaluation of a Binational Public-Private Strategy.
Necessary say thank you, Elsa Villarino, to give support to develop this study. And it's a great opportunity to give past and new generations to take experience, and it's a pleasure to me present Diana Telles. She's a new talent in my office, and this day is your anniversary. Happy birthday, Diana, and this auditorium is yours. Thank you.
Good morning. My name is Diana Telles, and today I have the honor to present on behalf of the authors of this work, Evaluation of a Binational Strategy for Tuberculosis Culture and Drug Resistance Testing in Northern Mexico. Northern Mexico shares a 3,000-kilometer border with the United States The TB incidence in this region is amongst the highest in the country. In particular, the state of Baja California and its largest city, Tijuana, have the highest TB incidence compared to all other states and large cities in Mexico. The Tijuana-San Diego border is the world's busiest international land border, with 14 million cars and 7 million pedestrian crossings annually. In Mexico, tuberculosis is diagnosed by microscopy conducted at quality control laboratories. All mycobacteriologic public health laboratories are certified by Mexico's reference central laboratory known as INDRE. Culture and drug susceptibility testing, DST, are normally only done for cases suspected of having drug resistance due to the treatment failure. Expanding capacity for culture and DST is a priority of the National TB Program as part of the Global Stop TB strategy. There are approximately 250 cases of multi-drug resistant tuberculosis diagnosed annually in Mexico. The last National TB Drug Resistance Survey conducted from the 2008 to 2009 estimated that this number represents only 35% of the expected annual MDR-TB patient caseload for the country. Our project had three objectives. One, to investigate the MDR-TB prevalence rate in Tijuana, Baja California, Ciudad Juárez, Chihuahua, and Reynosa, Tamaulipas. These three cities are sister cities to San Diego, California, and to El Paso and McAllen, Texas, respectively. The second objective was to evaluate the feasibility and cost of a strategy that included sputum transportation by airplane and TB culture and DST for all TB suspects, performed at Laboratorios Médicos Especializados, LME, in Ciudad Juárez, Chihuahua. And the third and the last objective was to compare our DST results to the results of the National Drug Resistance Survey. We conducted a population-based cross-sectional study that enrolled, regardless of age, persons suspected of having primary never treated tuberculosis in Tijuana, Ciudad Juárez, and Reynosa, from the 15th of May to the 15th of December 2016. We used locally hired staff that was trained on the use of a single questionnaire, on the collection and transportation specimens, and on results reporting. The best quality specimen of 3 taken for local TB diagnosis was selected, properly stored, and safely transported to the laboratory by car, in the case of Ciudad Juárez, or by commercial airplane, in the case of Tijuana and Reynosa. This was done every Monday and Wednesday to ensure delivery in less than 72 hours after their collection. The LME laboratory performed the following testing algorithm on all specimens received: smear by fluorescent stain, culture by metered and Lowenstein Jensen media, MTB complex identification by SDTV MPT64, and DST for isoniazid, rifampin, and ethambutol by solid media, and for PCA by liquid media. When resistance was identified to rifampin, secondary DST, and for seven additional drugs listed in this slide was performed. During the 7 months the study was open for enrollment, there were 220, 120, and 70 73 specimens submitted by Tijuana, Reynosa, and Ciudad Juárez, respectively, for a total of 413 patients. The majority of TB suspects studied were male, especially in Tijuana, and their mean age of 38 years and proportion under 18 years. Did not vary significantly. Did not vary significantly among the three cities, nor by whether or not MTB was cultured from their sputum specimen. Of the 1,413 specimens received, the LME laboratory had mycobacterial growth in 394. Of these, 385 were identified as MTB complex and 9 as a non-tuberculous mycobacteria. Of the 385 DST performed to the first-line drugs, 343 specimens were susceptible to all 4 drugs, and 42 had some type of drug resistance, including 5 with resistance to rifampin alone or in a combination with other drugs. More than half of the patterns of drug resistance were to a single drug or monoresistant. There were 4 patients that had TB resistance to INH and RIF or MDR-TB. 2 of these had additional resistance to 1 or more drugs. The results of testing to the second-line drugs showed susceptibility to almost all drugs, with the exception of rifabutin. Tijuana had the only patient with rifampin monoresistant disease. HIV testing or documentation of HIV infection status was not done as part of the study. 4 patients with MDR-TB were residents of Reynosa and Ciudad Juárez. Tijuana had 12 cases with monoresistance to PCA, compared to 4 cases in Ciudad Juárez and 1 case in Reynosa. INH resistance was similar in all 3 cities. In conclusion, the MDR-TB prevalence was relatively low, 1.3%, and almost unchanged from the national 2008-2009 survey. Drug resistance was more likely against isoniazid and PCA. The intervention included effective treatment in 5 patients with RIF resistance. The low levels of MDR-TB among never before treated patients are indicative of limited person-to-person transmission. Our single specimen courier-based central laboratory diagnostic strategy was successful, had negligible losses, included 9 identification of NTMs, and was labor-intensive and costly. The results of this study will be used for planning future programmatic changes. In 2018, Mexico Public Health Laboratories will begin an adaptation of a gene expert-based primary TB diagnostic strategy. This innovation is expected to provide affordable, sensitive, specific, and timely detection of both drug-sensitive and drug-resistant TB for patients in all 32 Mexican states. In closing, we would like to thank the institutions, personnel, and sources of funding listed here, and in particular the patients who agreed to participate in this proof of concept intervention. I look forward to your comments and questions. Thank you for your attention.
I think we have time for 2 questions. I'll start. I'm kind of interested in the Bovis flag. So So with the PZA-resistant strains that were primarily in Tijuana, right? Did you do any other microbiological work on those to confirm that they were M. bovis? Maybe you said this and I missed it. Okay, you go ahead.
No, we don't do any other proofs.
Okay, thank you. Last question, microphone.
Yes. Hi, Renee Ridson from CDC. Thank you, Deanna, for a very nice talk. And I'm not sure if this was included in the last question, but in the conduct of this study, did you have any of the specimens also tested by gene expert and in the lab, in the referral lab?
No, we don't have. With the gene expert, to some patients, especially like pediatrics, but we don't have the results reported because it's not in the ¿cómo se llaman? De criterios de inclusión. Criterios de inclusión. Inclusion.
I think the plan is to do gene expert next.
Criterios de inclusión, pero ya lo dije.
Okay.
Yes.
Okay, perfect. Very nice work. Thank you.
Thank you.
Thank you for your question. Close to my heart here is Hae Young Kim, and she's looking at the yield and cost effectiveness of mass digital chest X-ray screening for TB detection in South African correctional facilities. Thank you, Hae.
Thanks for the opportunity to present our work on behalf of my colleague at Johns Hopkins and in South Africa. Here is the outline of the talk. And yesterday we saw a couple of studies in correctional facilities worldwide. And I'm going to start with a little bit background about TB in correctional facilities. Based on the available data, it's been estimated that prison populations have 23 times higher TB instances than in the general community. This map shows that worldwide prevalent TB cases in prisons. In East and Southern Africa, 5% of inmates have TB, and furthermore in South Africa, 5% have co-infection with both HIV and TB. Last year, Lancet dedicated a special series to TB and new infection in HIV in prisoners. And I think this diagram really well captures why there are more TB cases in correctional facilities. It's often overcrowded with poor ventilation and poor nutrition, and frequent transfer between cells amplifies transmission among inmates. And once they are released back to the community, those with poor health status and at a higher risk of HIV/TB are likely to reincarcerate it back and continuing the cycle. Thus, in 2013, WHO updated their guideline to recommend symptom screening and, if available, chest radiograph as initial TB screening among inmates. However, only 5 countries in Sub-Saharan Africa currently have a dedicated guideline for HIV/TB management care in prison settings, including South Africa. There are various challenges for mass TB screening in prison settings. A cross-sectional survey in Southern African prisons show that cough of any duration would only detect with a sensitivity of 35% with a specificity of 38%. So a lot of TB cases are asymptomatic, thus undiagnosed. But the study also showed that adding chest X-ray to cough led to a much higher sensitivity of 80%. So in 2013, the South African Department of Correctional Services, in partnership with local NGO, launched a systematic TB symptom screening followed by gene expert test for those symptomatic in correctional facilities. The initial rollout data was analyzed and published in 2015, and this diagram here represents the screening flow of the program. There was a screening team evaluating for TB symptoms, and all inmates were asked to produce sputum samples if possible, which were then sent to gene expert test, and the results were sent back to correctional health staff within 1 day. And the analysis showed that among 7,000 inmates, 2% were diagnosed of TB, and most were able to be linked to initiate TB treatment. Then with additional funding available, a new program rolled out to screen using both symptom screen and mass chest X-ray across all South Africa starting 2015. So the objective of the current analysis was to estimate yield and cost effectiveness of mass digital chest X-ray screening for TB detection in South African correctional facilities, especially among asymptomatic inmates using the routine program data. We retrospectively reviewed the program data from 64 facilities in 4 North provinces in South Africa from January to December 2015. Under the program, inmates were initially screened for symptoms as before. Then the program had 6 mobile chest X-ray units available, and each inmate was supposed to be tested, provided for chest X-ray, and each X-ray unit was also attended by radiology technologists who were able to read the chest X-ray and provide immediate diagnosis of abnormal chest X-ray results. Then those with the symptoms or abnormal chest X-ray were asked to produce sputum samples, which again was sent for gene expert test. The outcome of the study was the number of microbiologically diagnosed TB cases among symptom positive and also among asymptomatic inmates who were tested by gene expert based on their abnormal chest X-ray results. We also estimated the cost for additional TB cases detected via chest X-ray among inmates without symptoms. A total of 62,808 inmates were screened for initial symptom screening. The median age was about 32 years with a median duration of incarceration of 1 year. About 60% were either newly admitted or currently incarcerated inmates. 4% had a history of TB in the past, and 4% were known HIV positive. This flow diagram summarized the yield of mass X-ray screening in the program. So overall, we saw 56% were symptom positive, and of these, 43% were additionally received chest X-ray. 76% were tested for gene expert, and overall we found 0.75% were gene X-ray positive, with a slightly higher yield of 2% on asymptomatic inmates with abnormal chest X-ray. So this would approximate the prevalence of TB cases in correctional facilities in our setting at about 420 per 100,000 inmates. Among those with symptoms, chest X-ray was done at about 73%. And since there are 6 X-ray mobile units available to cover all these 64 facilities, X-ray could not be done at all asymptomatic inmates. But of these, about only 35% were able to produce sputum samples tested to gene expert, and their gene expert test results were available. Finally, we detected 6 additional cases, TB cases based on chest X-ray at about 1% as gene expert positive. So using this yield data based on the routine program as you saw before, we ran a very simple costing analysis in a hypothetical cohort of 1,000 inmates. For epidemiology parameters, we took them from the program data we saw before. For example, we assumed that about 80% those eligible participants would be tested for gene experts. We assumed a slightly different probability of testing positive for gene expert based on the symptoms in the chest X-ray result. The unit cost for mobile chest X-ray per individual was about $17 as a part of the routine program. Then we estimated the unit cost for X-ray per additional TB cases detected. So in a hypothetical of 1,000 inmates, 3 TB cases would have been detected in symptomatic individuals based on gene expert test. 317 with asymptomatic and eligible received chest X-ray, And this table shows the number of TB cases that would have been undiagnosed under each screening method. Using symptom screening only, 2.6 TB cases would have been undiagnosed, but with symptom and X-ray screening, 2.35 cases would be undiagnosed in 1,000 inmates. So allowing to detect 0.24 more TB cases based on X-ray screening at a total incremental cost of $5,377. This is the usual in the unit cost of X-ray per additional TB cases detected using X-ray at around $22,400. The user would be sensitive to the probability of abnormal X-ray and proportion of gene expert tested positive with other parameters. So there are a number of limitations in our analysis. As you saw that we only include costs associated with mobile X-ray units. Costs for gene expert TB treatment or linkage to health services were not included, mainly because we are just looking for the unique cost due additional X-ray among asymptomatic individuals, and we assume that asymptomatic individuals will tested for gene expert anyway. We also didn't evaluate the potential values of using X-ray for diagnosis of clinical TB or other lung disease. So in conclusion, having X-ray in addition to symptom screening was feasible in correctional facilities in South Africa and added yield of gene expert positive TB, but also added a considerable cost to the program. X-ray among asymptomatic inmates with abnormal chest X-ray result will detect about 24 more cases per 100,000 inmates. And the high proportion of inmates reporting symptoms, which was about 56% in our setting, may have affected the cost effectiveness of X-ray. So with that, I will acknowledge our colleague at Johns Hopkins in South Africa, and I will happy to take any questions. Thanks for listening.
Thank you so much. I think we'll open it up for a couple of questions. There's 2 microphones in each of the aisles if anyone wants to come up. And while we're waiting, thank you for that presentation. It was really quite interesting. I have a question, which is one of the things you noted in your limitations and conclusions was that over half of individuals reported symptoms. Which is quite unusual. It's not a health facility. This is entering into an incarceration. Yeah. And I'm wondering if you think that's why that is, and if you think that's representative of what you'll typically see in people entering into incarceration. Because obviously, as you mentioned, that really affects the cost effectiveness because there's so few people who are presenting as asymptomatic.
Yeah. So I think our setting was unusual, or our data unusual, because we saw really high symptomatic individual in inmate setting. I'm not sure because we were just ruling out the initial TB screening in massive way. So initially we saw a lot of symptomatic cases, but I think in other settings the symptoms could be like 10% or much lower. Then definitely that will be need to consider if it can be applied for the other settings, even within the South Africa.
We'll start over here.
Gavin Churchill from the Aurum Institute, who actually implemented this program. And the high proportion of symptoms is not unusual at all. This is fairly common in correctional facilities. And it's important for why x-rays are done. What you haven't highlighted that is if you did culture rather than expert, the added value of doing x-rays would be greater. Because expert with active case finding has much lower sensitivity.
Mm-hmm. Yeah. Thanks for the comments. Okay.
Thank you. You have a huge amount of data that you managed to get into a very good presentation. It's very interesting. And I may have missed this, but I thought that you said the prevalence of HIV in this population was about 5%. Was that correct? That's quite different than the prevalence in the outside population, which is much higher. And so I'm surprised to see that. Do you have any thoughts of how you account for that difference in the prevalence?
Yeah, so we asked for whether we offer the HIV testing, and not all of them were actually consented to test it for HIV. So that was only for among those who were known based on our HIV test results. So I think including for those who were unknown HIV, the HIV rate could be much higher than what we saw. Thanks.
I'll ask one last question, which is, I think that your conclusion of your cost analysis was that the cost per case was about $22,000, if that's correct. And one question / suggestion is if you've considered, to put that in context, what is the, as you mentioned in your limitations, what's the cost of actually caring for patients who are diagnosed later, but also, of course, the risk of transmission. We're talking about settings where transmission is quite common, and so it's not just about the cost of that individual case, but all the individuals they could potentially transmit to within the setting.
Yeah, so thanks for the comments. I think that's very important that we only, so as I said, it was very simple costing analysis, but obviously the preventing HIV transmission, TB transmission and diagnosing more TB cases would have additional benefits to preventing further TB transmission in other inmates. So that should be considered as added values maybe for the further analysis.
Thank you. Norbert Heinrich, and his presentation is entitled Rifampicin Dosage and Exposure are Associated with Superior Activity in the Panacea MAMS TB Study.
Put on an orange tie and want to tell you more about high-dose rifampicin. Much has been said about this already, but we think there's more to the story. What I would like to present is a post-hoc analysis from the MAMS study where the primary results have already been published. To get into details, the study was an open-label study conducted in South Africa and Tanzania, assessing 4 different experimental treatment arms. Patients were seen weekly up to 12 weeks, and the primary endpoint was the time to stable culture conversion in liquid media. For this analysis, what I'd like to look at is the MITT population of 363 patients from these altogether 5 arms. And there was an intensive PK sub-study collected, yielding data from 97 patients. So this has already been shown a couple of times. This was the study design. 1 control arm with standard 4-drug treatment and 4 experimental arms with different doses of RIF. I'd like to focus on the arm with the highest dose of rifampicin, 35 milligram per kilogram, as you can see here, given for 12 weeks. And then there were 2 other experimental arms with 20 milligrams per kilogram of RIF with an experimental 4th drug, and 1 arm with 10 milligrams per kilogram, the standard dose, that was of course also used in the control arm. Now these RIF doses were of course given in a weight-banded way, and this resulted then in a range of different absolute doses that patients received, ranging from 450 milligrams, which were received by the highest number of patients, up to 2100 milligrams, which were still received by 23 patients. And as you can see here, the high-dose rifampicin arm with its 63 patients contributed 38 patients to the 1500 milligram absolute dose, and those 23 patients to the 2100 milligram dose. Now the headline results that have already been published per arm have shown that the high-dose rifampicin arm performed better than the other arms. You can see in this Kaplan-Meier curve of patients converting to negative culture over time that they received the treatment over 12 weeks. The green line is the 35 milligram per kilogram arm, which was better than the control at a hazard ratio adjusted of 1.8. Now looking at doing a similar analysis again just by rifampicin absolute dose led to the somehow surprising finding for us that actually most patients receiving different RIF doses seem to have achieved culture conversion in a relatively similar way, as you can see, and it was only the 2100 milligram receiving patients which were really outstanding in their time to culture conversion and converted much faster. This translated into a hazard ratio of 2.8, and of course this was not a randomized comparison but a post-hoc analysis. So we tried to look at baseline variables of these patients that might have explained such a difference and confounded our interpretation of the RIF dose being the most determining factor. I'll just walk you through the baseline factors quickly. Of course, weight was different, and the 2100 milligram cohort had a higher weight, not surprising because, of course, this determined the rifampicin dose. This cohort had a higher proportion of male participants, which with regard to our study outcome was actually a disadvantage. There were slightly more HIV co-infected patients in that cohort, and, which was favorable here, as you can see, this is time to detection in midget at baseline, and a higher number here means that they actually had a slightly lower bacterial load at baseline than the others. So putting all this into a multivariable Cox regression analysis resulted, so correcting for baseline bacterial load, again, gender and percent visits without culture results, which of course affected the time to negativity endpoint. This resulted in the overall hazard ratio of 2.8, which it was actually the same as in the univariable analysis. What you can see also here is that the hazard ratios for the other rifampicin doses were not significantly different from one. As I said, this was a 12-week study, so that was a bit unusual in the context of phase 2b studies. So we truncated this in the data set to an 8-week study to be, provide a comparison to other phase 2b studies that had been done, and this resulted in the hazard ratio of 3.3. Also adjusted for the same covariates. Now, Martin Bourret often shows a slide of rifampicin, hypothetical rifampicin dose response curve, and I've tried to graph this here now based on our data, of course with the limitation that it's post hoc, but what you've already seen is that with the hazard ratios from the multivariable analysis graphed here related to, of course, 450 milligram dose as the baseline stratum, you can see that there is basically not much changing until we reach this really high dose. And we can debate about the shape of this dose response curve. You could probably fit a straight line through this with the confidence intervals being as they are, but it could also be a sigmoidal curve. This is still something that needs to be determined also for the dose response model. Another variable that can be graphed in this way is the proportion of patients who achieved the culture negativity endpoint over 12 weeks. Again, this is in liquid media, so it's a relatively low proportion achieving a culture negativity endpoint. But what you can see here as well is, again, up to 1500 milligram, there's not a lot of change, and significantly higher proportion of slightly above 90% achieved culture conversion when they got 2100 milligrams of RIF. Now, of course, these high doses always raise concern about safety. We didn't have a really huge number of patients, but nevertheless I'd like to show the numbers of patients suffering hepatic toxicity that was so severe that treatment had to be interrupted, paused and restarted or stopped altogether. And as has been shown before, we had, a slightly higher proportion of patients, 3 out of 41, in the 1500 milligram cohort having hepatic events, and 1 patient out of these 23 with the highest dose. So comparing these two, there is not, with the limitation of small numbers, but there is no really safety signal that would be strongly apparent. Now, the driver of efficacy is, of course, the concentration of the drug in the body, and plasma being the compartment that we can measure. Some data from the intensive PK subset showed, and the red dots here is a scatter plot of area under the curve versus dose. And you can see that the red dots, which were the patients from the 35 milligram arm, show a clear distinction, as we would expect from the efficacy results, that these patients actually had a lower area under the curve than the 2100 milligrams. So these two doses should actually have resulted in the same per kilogram dose. So they should have kept the exposure pretty constant between those two weight bands, but excuse me. Obviously, we overcorrected with our weight banding, and the higher doses resulted in higher exposure than the lower dose. And well, looking more at the dose exposure, our colleagues in Nijmegen established a model to describe the exposure, and that model includes the absolute drift dose, gender, not the total body mass, but the fat-free body mass as the best predicting parameter. The fit with an R-square of 0.83 is quite good, but that's of course over the entire large dose range of RIF given in the MUM study. If we include dose per weight instead of the absolute RIF dose, the fit is slightly less good, but it's still highly predictive over this dose range. And as you'd expect, the area under the curve was of course significantly correlated with time to culture conversion. More details on this exposure response analysis and on the models will be presented at the TB drug PK meeting in Atlanta on Sunday and at InterTB in London. And of course we hope that the publications will be accepted relatively soon. Now to conclude, our post-hoc analysis suggests that better activity within the doses that we studied was only apparent at a RIF dosage of 2100 milligram. The exposure was clearly related to this absolute dose. Our weight banding had not worked and had overcorrected for an increase in drug clearance that you would expect in people with a higher body weight. What we need to do going forward is to improve our dose adjustment based on body weight, because we want to treat our patients in a way that they receive a relatively narrow range of exposures. We don't want patients on the one end to have a very high exposure, to have perhaps an increased risk of toxicity, or on the other hand to have a very low exposure and have the risk of insufficient efficacy. And we will be able to use, of course, the exposure response models that were developed by Elin and Robin Svensson for this. Excuse me. Now, it's of course difficult to translate a hazard ratio into treatment shortening, if not impossible. So we'd have to get back to the mouse, and this is just a informative slide provided by Jan Min Hu from London, and she was able to show in her Cornell mice, treating them over up to 14 weeks with different doses of RIF. The numbers you can see here is the maximum probable numbers of resuscitation promoting factor dependent persister organisms. You can see that at the normal dose after 14 weeks the lungs were not sterile from these persister organisms, but as the rifampicin doses increased, it seems to have been possible to sterilize these lungs even after 8 weeks of treatment. Also, this data is currently under publication. So I'd like to acknowledge the Panacea Consortium, and for this analysis especially Patrick Phillips, Lindsay, Elin and Rob from Nijmegen, and Sarah and Michael from Munich, and of course our donors, without whom all this wouldn't have been possible. Thanks very much.
I'm going to ask actually that we hold questions because we're running a little bit late on time, and I want to make sure we have time for the presentation. So we'll have a little bit of time at the end. So no questions right now. So our next speaker will be Alberto Garcia Bacero, and he will be speaking about his presentation. His title will be "What is the true tuberculosis mortality?"
I'll start with a very disappointing remark. I won't be able to tell you what the true mortality burden is, but I hope I can provide some insight on what the differences in the currently available estimates are, and what factors might be driving those differences. As a conflict of interest disclosure, I have collaborated with WHO, attending different meetings and with some WHO documents, and I'm also part of the GBD collaborative network. So, why is it important to measure TB mortality? So it's important for establishing health priorities. It's important to know where tuberculosis ranks among the health concerns for a given country. It's important to monitor the TB case fatality rate, and it's important to monitor TB control activities and health programs that want to impact on mortality. on a global scale is important also for the assessment of the NTB main indicators. As you know, the trends in mortality is one of those critical indicators. So, who are the main institutions producing global TB mortality estimates? On one hand, we have the World Health Organization, which for the last 20 years have provided estimates of TB mortality in the Global Tuberculosis Report, which is released every year on October, November every year. So they are about to release this data from 2016. And also the Institute of Health Metrics at the University of Washington in Seattle, that under a big project quantify the burden of different diseases, risk factors, and conditions. And they do this in the Global Burden of Disease Project, which is also published annually in The Lancet around September, October. So there is one article published by the Institute of Health Metrics specifically on tuberculosis, which was dealing with data from 2013, and that allowed a comparison with WHO data, and with data from 2013, WHO estimated 1.5 million deaths, and the Institute of Health Metrics estimated 1.4 million deaths. So they are quite similar. If we stratify by HIV status, we see that already some differences. The WHO estimated 400,000 deaths among TB, HIV positive cases, and the Institute of Health Metrics 100,000. These differences are not only in mortality, but also in incidence, where the WHO for that year estimated 9 million incident cases and the Institute of Health Metrics 7.5. So the objective of this study was to compare the mortality estimates by WHO and IHME for the year 2015, and also to explore which factors might drive the observed difference at national, regional, and global level. So a little bit on the methods, definitions, and concepts. I'm going to highlight the main differences. Of course, the WHO and IHME use different mathematical models to come up with those figures. Interestingly, the IHME uses data derived from verbal autopsies from some countries. The WHO doesn't do that. The WHO uses case fatality rates for some countries where there is no vital registration data, and that's not used by the Institute of Health Metrics. The WHO publishes with a great level of detail their methods as an appendix in the last couple of years of the Global Tuberculosis Report. The information we have publicly available from the methods to come up with tuberculosis mortality estimates from IHME are more succinct. So what did we do? We extracted data, open access data from the WHO and IHME web pages, and we extracted data that was stratified by HIV status, age, sex, and country, and we created a master data set with raw data from those sources, data set that will be hung online when the manuscript is published. We also included some interesting variables that could be related to the observed differences, such as case detection rate, MDR prevalence, case fatality rate, or HIV prevalence. So we calculated the absolute differences in mortality estimates with both methods, but we believed that this was not a good metric because the absolute difference doesn't take into account the population size of the country, and more importantly, the TB burden. So we standardized the absolute difference between methods by a proxy of the mortality burden in the country, which we consider could be the average number of deaths between WHO and IHME. So we call this metric STAND-DIF, like the standardized difference. So that is created with this formula, the absolute difference in the numerator, and in the denominator the average. So if WHO estimated for a given country 4 deaths and IHME estimated 2 deaths, that metric would yield the value of 0.7. But since this metric is not easily interpretable, we rescaled the STANDIF into a minus plus 100 scale using the relative difference as a proportion of the maximum value obtained. So a positive score would be when WHO estimates more deaths than IHME and vice versa. And we did some analysis, ecological analysis, to see the association of STANDIF with some covariates such as case detection rate, prevalence survey, the existence of a prevalence survey, case fatality rate, HIV and MDR prevalence. So these are the results. So in this table you can see the estimates, the number of deaths estimated by IHME, here the estimates by WHO, here is the absolute difference in mortality estimates, and here is the relative difference, here considering WHO as the reference, so 100%, and here considering IHME figures as the reference being 100%. So what we see is that between the estimates of WHO and IHME, there's around 450,000 deaths difference, which is considerable. If we stratify by adults or children, we see that there is a remarkable difference in HIV, TB, co-infected estimated deaths. So basically, the WHO estimates double than IHME. Another big difference is in children with TB, no TB HIV, and this also goes in line with the uncertainty that we believe we have in pediatric tuberculosis burden. We didn't see differences by sex. So overall, when we correlate the figures of IHME and WHO, we see that they are pretty similar. Even by region, they are very similar. So this made us think that perhaps the difference concentrates in a few countries only. Here we see by region in this violin charts, we see that in countries with good viral registration data, so like in Europe, we see that most countries lie around zero of our metric. However, in countries in Africa, we see that they spread more broadly along the y-axis of our metric. Here we see the ranking towards WHO and IHME on the number of differences, and we see that Nigeria, Bangladesh, Tanzania are the countries which contribute more to this absolute amount of differences. On the other side, we have Ethiopia, China, Zimbabwe, where IHME estimates higher amount of deaths than WHO. So in this map, we pictured our indicator STANDIF. So when it's orange, it means that WHO estimated more deaths and with more intensity as the orange gets darker, and in green where IHME estimated more deaths. So here we have the countries, some countries where the absolute differences were great, but also some countries where the burden of disease is not that big, but the difference of the estimate is big with regards of what they report. So as an example, in the country where I work, in Mozambique, we can see that the overall number of deaths, according to IHME, is 25,000, according to WHO is 54,000. So what is the problem of tuberculosis mortality in Mozambique? Is X or is X times 2, right? Surprisingly, the difference is mostly in adults and not in children. And the difference in mortality is greater than the difference in incidence estimates. Okay, thank you. So what factors might be driving those differences? We didn't observe any difference by HIV prevalence among new cases. HIV prevalence as reported by the countries, not estimated by either of the institutions. We didn't observe any difference by MDR prevalence as reported by the countries. We did observe a difference with regards to case detection rate as estimated by WHO. So the lower the case detection rate, the more likely that WHO estimated more deaths. We estimated case detection rate with IHME figures that was not given, and we also found an association between the standardized difference and the magnitude of the difference in TB mortality estimates. We didn't observe a great difference depending on the WHO region. And we did observe a difference depending on whether the country had a prevalence survey from 2008 to 2015. We saw that the mean average was higher among those who had a prevalence survey, so WHO estimated higher deaths than among those who didn't have a prevalence survey. So when we get the correlation coefficient, removing those countries without a prevalence survey, we saw that it improves from 0.92 to 0.99. So the conclusions, different approaches to mortality estimates I think are welcome, but the difference in some countries I think deserve further work. The main differences are concentrated in a few countries. The use of prevalence surveys and case detection rates seem to be associated with different estimates, WHO estimating more deaths, and there is a need for reproducibility of the methods to advance in TB mortality estimation. So I just want to leave you with two questions. Is WHO estimating TB mortality? Is WHO overestimating TB mortality? So looking at our data, we saw that those countries with prevalence surveys, the WHO estimated more deaths. Could that be related that the case fatality rate of those cases found in prevalence surveys is different to those that from TB cases or suspects that come to the clinic? Or is IHME underestimating TB mortality? We know that IHME uses verbal autopsy among their parameters, and we've seen that is not a very good estimate for assessing TB mortality at death. So I just want to thank Joe Boo, Frank Kovalas, Martin Borgov, and Brian Williams for their support, as well as the CDC and the Union for their support. Thank you.
So we have one remaining speaker, so I'm going to ask Catherine Hewison to come up for the last presentation, and then we'll take questions for the last three presentations together after Catherine's presentation is complete.
So I'm very happy to present these results on behalf of my colleagues, and I hope that they'll be useful for clinicians in the field. So I'm going to present the early safety and efficacy of the delamanid and bedaquiline combination used for drug-resistant tuberculosis in Armenia, India, and South Africa. So delamanid and bedaquiline were both recommended for MDR TB treatment based on studies showing effectiveness, faster times to culture conversion, better culture conversion, and improved outcomes. Both bedaquiline and delamanid have effects on the QT interval. In clinical trials, bedaquiline had a mean increase after 24 weeks of 15.4 milliseconds compared to the placebo arm, which had 7.7 milliseconds. Delamanid had a mean of 12.1 milliseconds compared to 2.1 in the control arm. But in neither clinical trials there were any cardiac-related complications. As you know, in MDR TB we use other QT prolonging drugs, specifically clofazimine and moxifloxacin, and also non-TB drugs for comorbidities and for adverse events. Currently, there's very little documented experience on the use of delamanid and bedaquiline in combination. There's been 2 case studies published and 5 patients in an observational cohort. There are 2 ongoing trials that use the combination of bedaquiline and delamanid, the deliberate trial, which is specifically looking at the QT prolongation, and the NTB trial, which is looking for shorter, better, less toxic regimens. So Médecins Sans Frontières has supported national TB programs to use delamanid and bedaquiline combinations since 2016. And these are used in patients with limited treatment options. Patients without the necessary number of effective drugs. And this can be for several reasons. because of drug-resistant patterns or inability of the project to supply and administer imipenem, which as you know is IV twice per day, very difficult to administer in most programs, or adverse events, which are common, or any other contraindication. So here we're going to describe the early safety and microbiological efficacy of these regimens containing bedaquiline and delamanid in 3 epidemic hotspots: Armenia, India and South Africa. In South Africa, Kailicha is an urban township, has a very high HIV-TB co-infection rate of 70% and high burden of MDR-TB. In India, Mumbai is an urban setting, including a large slum, with high burden of MDR and very high second-line drug resistance. In Armenia, it's both a rural and urban setting with high MDR-TB and increasing levels of XTR. So this is a retrospective cohort analysis. The patients are consecutive patients who received the combination of delamanid and bedaquiline as part of an MDR-TB regimen between January and August 2016. It includes both patients who started delamanid and bedaquiline at the same time and patients who had the addition of either drug to an ongoing regimen containing the other. These patients received classic MDR-TB monitoring, but they had enhanced ECG monitoring. So this was 2 weekly during the first 3 months of treatment and then monthly after that. We corrected the QTC interval with the Frederica formula, as it's supposed to be the best to pick up the QT problems, and we are going to present the QTCF in the first 6 months of combination therapy. Serious adverse events were reported to the MSF Pharmacovigilance Unit in Geneva. Serious adverse events are adverse events leading to death, hospitalization, congenital malformations, disability, or other life-threatening. We are going to present the serious adverse events in the first 6 months of treatment. We define culture conversion as 2 consecutive negative cultures at least 15 days apart in patients who are culture positive at the time of starting the combination. So there are 28 patients included in this analysis. The median age was 32, and importantly, 75% of patients had previous second-line treatment. Additionally, over 85% had fluoroquinolone resistance, and 40% were HIV positive. The MDR-TB regimens contained bedaquiline delamanid, and these are the other 4 drugs that the majority of patients received. In terms of the QT prolonging drugs, 75% of patients received either clofazimine or moxifloxacin in addition to delamanid and bedaquiline, and 7% received all 4, clofazimine, moxifloxacin, delamanid and bedaquiline. So here are some results. This is the culture conversion results. At 2 months, the culture conversion, at 2 months the culture conversion was 40%. And after 6 months, it was 74% amongst the 23 patients who were culture positive at baseline. Amongst the patients who didn't culture convert, 2 were culture positive at month 6, 2 had 1 negative culture at month 6, 1 was lost to follow-up, and 1 could not produce sputum. Of the 5 culture negative at baseline patients, they all remained culture negative. 1 patient died before 6 months. So at 6 months, 26 patients were alive and retained in care, which is 93%, and of those, 82% were culture negative at 6 months. Serious adverse events. So there were 16 serious adverse events reported in 7 patients. 6 were considered possibly related to delamanid, bedaquiline, or to both. 11 were considered possibly related to other TB drugs. The most common serious adverse events were gastrointestinal, nervous system disorders, and psychiatric disorders. The majority of serious adverse events resolved, although 1 was not resolved as a peripheral neuropathy. One was resolved with sequelae, that was a psychiatric disorder, and one patient had a fatal outcome. It was a patient with 2 SAE events reported, a HIV patient who suffered from immune reconstitution syndrome. There was no temporary discontinuation of bedaquiline or Delamid. Now to the QT prolongation. So this shows the distribution of the median QTCF at each time point. So at baseline, the median QT was 401. At 2 months, it was 430, and at 6 months, it was 434. As you can see, no patient had over 500 milliseconds, and there was no clinically significant cardiovascular events or arrhythmias. This graph shows the distribution of the mean difference in QTCF at each time point from the baseline. So the mean difference at 2 months was 8 milliseconds, and the mean difference at 6 months was 16 milliseconds. 4 patients had 6 episodes of an increase of 60 milliseconds. 1 patient stopped temporarily the combination for 1 week but was reintroduced, but none led to a permanent discontinuation of the drugs. Amongst the patients who had the increased episodes of more than 60 milliseconds, 1 patient was receiving 4 QT prolonging drugs, clofazimine, moxifloxacin, Delamid, and bedaquiline, and the other 3 were receiving 3 QT prolonging drugs with Delamid, bedaquiline, and clofazimine. So in conclusion, these show good early safety and efficacy results in difficult to treat patients with second-line resistance and previous treatment. It's a multi-centric cohort from different programmatic conditions. QTCF prolongation was not found to be a safety concern in this cohort of well-monitored patients. Delamid and bedaquiline combination is certainly necessary in many patients who don't have enough effective drugs. And we think that further support should be given to programs to treat effectively these patients that require a combination. Thank you to the patients and to all the people who have contributed to the analysis.
Thank you, Catherine. In the few minutes we have remaining, I'd like to open up to questions for the last 3 presentations. So that was Norbert Heinrich's presentation about high-dose rifampicin, Alberto Garcia Becerra's presentation about mortality measurement, and Catherine Hewson's presentation on combination bedaquiline and Delamid.
While we're waiting, maybe Catherine. So there's 1 death that had immune reconstitution, acute renal failure, and hypoglycemia. I would say maybe all 3 are preventable. Certainly immune reconstitution is. I think hypoglycemia is. And I'm wondering if they were on a tenofovir-based regimen.
The patient hadn't been put on ARVs, but this was the patient refusing. No, yeah. So, yeah, these patients were very sick, and these are programmatic conditions, but of course all HIV positive patients get put as soon as possible onto ARVs, but this particular patient not. No.
So let's go to the question here at the microphone.
Thank you. It was a very interesting presentation about the discrepancy between the estimates of IHME and WHO presented by Dr. Alberto. The discrepancy mainly stems from the use of different approaches to deal with a lack of high-quality data for low and middle-income countries. To estimate mortality, WHO back-calculated mortality based on incidence adjusted by the expert opinion case detection rate and case fatality estimates. In contrast, IHME, for countries without vital registration data, IHME used verbal autopsy data and used a combination of covariates and borrow strength across space and time to predict for locations with limited or no data. As for the underestimation, likely due to the use of verbal autopsy studies, actually one cannot actually say whether there's an overestimation or underestimation until one look at both sensitivity and specificity as well as the cost fractions of TB death. This was a multi-center verbal autopsy validation study conducted, and according to that study, at the typical cost fractions of TB deaths at 3 to 5%, and at the reported level of sensitivity and specificity, the false negatives and false positives largely canceled each other out. And going back to the lack of high-quality data for low and middle-income countries.
Sorry, we don't have much time left. Do you have a question for the speaker?
I think because the speaker asked questions about IHME and WHO estimates, I think I have one last comment. Why this discrepancy occurred? It is because there's a lack of high-quality data for low and middle-income countries, and IHME and WHO use different approaches. So the only solution to this problem is to make more high-quality data available. So the importance of strengthening vital registration systems have been increasingly well recognized. But until such systems are fully developed, various options have been suggested in the literature, including the use of sample-based mortality surveillance, like the one conducted in China, to increase the robustness of cause-of-death data.
Thank you so much for the comment.
Thank you.
I'll turn to the last question.
Is for the presentation on high-dose rifampin. I'm Elsa Villarino from the Centers for Disease Control. And I had two questions. Could you comment on drug interactions with antiretroviral therapy if your patients were on it? And the second one is if rifampicin, another rifamycin that could be dosed at higher doses, is going to be considered as part of high-dose rifampin regimens.
Thanks for these questions. Certainly the question of interaction with RIF is a very important one, but unfortunately I can't really answer it. We know that RIF at a standard dose produces strong interactions, but we don't know yet whether these higher doses change anything in the interactions. There seems to be some indication that they wouldn't, but that's certainly not hard data. I know that our colleagues in Nijmegen are trying to look at that. The next question on rifampicin, you're right that rifampicin is currently being looked at in the TBTC study. I think it's 32, at least that's a phase 3 study for treatment shortening using that drug, and I guess there will be some years until we see those results. Maybe one small difference between these two drugs, rifampicin seems to be much more highly protein bound and much less water soluble, and I don't know if you've seen the analysis by Radha Savage on the TBTC data, where she suggested that rifampicin seems to, well, high doses of rifampicin don't seem to benefit those patients as much who have really large lesions and have really, I don't know, more severe disease, while rifampicin, as we know, penetrates lesions well. So there might be a difference evolving between these two drugs in the future.
We'll have one last question.
Yeah, just a comment in response to your comments, because I'm a co-investigator on the work on mortality. I mean, clearly you're right. I mean, we don't know, and clearly there is a need for better vital registration data. We all know that it's going to take decades before we have them. In the meantime, we have largely discrepant estimates, and I think it is the role of scientists to take a proper look at that and to see what kind of hypothesis it raises and whether those hypotheses can be addressed. And I think just saying that we need to wait until we have better data, I think that is not the role of scientists.
So I'll give Alberto a chance to give the final word on the matter, and then we'll wrap up.
Okay, so thank you very much for the comment. We all agree we need higher quality data, but I don't think that there's been like many studies assessing the accuracy of verbal autopsies against full postmortem examination. The example you gave, I think it was in general for infectious diseases, but specifically on tuberculosis, I don't think we have a lot of evidence published. There's one symposium this afternoon who's going to show some results in Kenya and in South Africa saying that verbal autopsies are not, or concluding, I think, that verbal autopsies are not a very good tool to assess cause of death in tuberculosis specifically. But I mean, further work is needed, and I look forward to seeing it also from IHME, of course.
I think we were going to wrap up. Any further discussion, feel free. I think the speakers, maybe I'll ask them to stick around for a few minutes to answer further questions and speak. I want to thank all of our speakers today. It was an amazing group that I think we went through a wide variety of topics, and I really appreciate all of the high-quality work that each of them are doing. I want to thank my co-chair, Wendy, for helping organize the session, and all the audience members for sticking around and listening to, I think, some really important work and findings that were presented today. So thank you again, everyone.